So this All right, good evening, everyone, and welcome to the annual Spectacular Problems in Surgery, and the first time this has been done virtually. So there are several people in the room, and there are several people online here, and we will go ahead and get started. First spectacular problem, robotic traumatic hernia repair after a blunt impact with a projectile. This projectile being a beer keg, to be presented by Dr. Jonathan Jew from the University of Illinois, Peoria.
Great, thank you very much. I'm just going to get my screen shared here. All right, we'll run this full screen. There we go. Okay, can everyone hear me? Okay, perfect. I'm Jonathan. I'm one of the second-year residents at the University of Illinois at Peoria. Thank you very much for having me start off the night here. And my presentation is on a robotic traumatic hernia repair after a blunt impact with a projectile beer keg. So the story goes that this was a 48-year-old male who sustained a blunt force trauma to his abdomen from an exploding beer keg. He worked as a farmer with his brother, and they were burning trash in a fire pit when they were accidentally threw a keg that was unintentionally pressurized onto that fire. Given that heat, the pressure ended up overcoming the integrity of the keg itself, and it became basically a projectile missile. It exploded and struck the patient, who was over 200 pounds, knocking him over, and then continued on through two sheets of corrugated metal, which was the barn door and the barn wall behind him, and then continued through that building as well. So we actually have pictures from the incident. As you can see, the pictures show the fire pit as well as the barn behind him. It also shows the surroundings of the fire pit. The patient was standing between the fire pit and that barn door. On a zoom in, we can see that there's these two sort of squarely cut areas. That was when the door was open. The keg went through the brown as well as the tan, and then continued through. So it was definitely a significant force. When when everything was said and done, he ultimately sustained injuries to his left abdomen and his left upper extremity. And when he reported to our trauma bay, our imaging immediately showed that he did have a dislocated left elbow. This was reduced and splinted at a 90-degree angle by orthopedic surgery. And then he was, so this is showing the dislocation, and this is showing the splint. The reduction is nicely done here. He was then admitted for evaluation of his traumatic injuries, and he stayed with us because of an obvious left abdominal defect. Because of this, and given his stable vitals, he underwent a CT, which diagnosed this defect as a traumatic spigelian hernia as well as a Morel-Lavelle lesion. So this is a CT. On the axial sections, we can see that he does have a hernia here with bowel protruding through. And then on other slices on the coronal view, we can see the Morel-Lavelle lesion on the left, and then the hernia once again demonstrated on the right there with bowel protruding through. So given these injuries, we elected to pursue an operative repair robotically. There was some issue with looking at the location of this lesion. We wanted to make sure that we could visualize it well, and he was stable enough to definitely undergo this procedure robotically. When we first got in the abdomen, we did notice some incarcerated small bowel that was easily reduced. There was a little bit of necrotic momentum noted, but all the bowel was viable after evaluation with the laparoscopic camera. We did then identify a defect that measured 7.5 by 6 centimeters with friable tissue and a shear injury exposing the left iliac crest internally. Given this exposed bone, we then elected to repair the internal and external obliques to cover that iliac crest using V-lock suture. And then the defect ultimately was closed with one stratafix as well as a V-lock suture for a final repair that measured 12 by 8 centimeters. With this repair done, the concern was for how the integrity of the repair and how it would hold up over long term. And given his traumatic nature, as well as the overlying Morel-Lavelle lesion, there was some concern for possible infectious source. So we elected to use a 20 by 15 centimeter phasic mesh that was just basically to cover this, but also allow for any of the sort of flexibility between a permanent versus a biologic mesh, so that if it were to become infected, it wouldn't, there would be nothing to remove if we had to go back and re-explore. This phasic mesh was then tacked with O-Vicryl at the corners, sutured circumventrally with V-lock suture, and then the capture tack was used to anchor the mesh to the iliac crest to make sure that it would not rotate or move out of place. The skin over the Morel-Lavelle lesion was then incised after this hernia was repaired, and exposed a 15 by 15 centimeter cavity. With the underlying fascia and musculature in place, we decided to place a wound vac in this dead space just to close down the space between the subcutaneous tissue and the underlying structures, and allow this wound to sort of heal by with secondary intention. His postoperative course was just complicated by an ileus that was resolved with conservative management. He was discharged on oral narcotics, and he did have a bit of a radial nerve palsy that was most likely secondary to his dislocated elbow. His first follow-up 2 weeks after his surgery, it demonstrated a very, very minimal seroma beneath his Morel-Lavelle lesion. Most likely it was from the wound vac sponge not being packed deep enough into that wound, but ultimately it was so small that the wound vac was discontinued and he was changed just to wet to dry dressing. His second follow-up a month later, that lesion was shown to be healed with just the wet to dry dressings, and no further dressings were required after that. His 3 months follow-up showed near normal return of function of his left arm, and his hernia repair was successful in repeat imaging, which demonstrated the integrity of that repair. Here we see this is a follow-up with the orthopedic surgeon showing that there's no other residual effects or artifacts from his dislocation and reduction. And then this is his repeat CT, which does show that the integrity of that abdominal wall has been restored. And then we see this too on the coronal sections as well, that the Morel-Lavelle lesion has completely healed, and that we don't have a recurrence of the hernia, even with the placement of the phasic mesh. So at 1 year follow-up, which was 4 months ago this year, he returned to clinic and had showed no clinical signs of hernia recurrence, and his Morel-Lavelle lesion never recurred either, and he had no other further complications from that seroma that presented a year prior. He's now returned to work as a farmer without difficulty, although I think he's going to be a little more weary about throwing beer kegs into his fire pit going forward. And that's it for my robotic trauma hernia repair after blunt impact with projectile beer keg. I'd like to open my time to questions at this point.
Great, thanks for sticking it on time and a nice presentation. This session is, or this paper is now open for discussion. Dr. DeBoer. Did you hear that?
I did not catch that, Dr. DeBoer.
He has a dinner for you waiting. He's got it in a takeout bag.
All right, thank you.
That's pretty good, getting a senior surgeon to get
That's right.
dinner for you. So, there's actually over 28 people watching this online. And I think that, some good has to come out of all of this, I think. And maybe one of the good things going forward is that there's a lot of people that can't travel for one reason or another to this meeting. And maybe going forward, it might be worth trying to organize this so spectacular problems and even the whole meeting can be put online virtually, so that people that can't make it to the meeting for one reason or another are able to participate. And if that's all that we get out of this, I think that'd be a great thing. But nice presentation. Being no other comments, we can go ahead to the next one. So the next presentation is, so with COVID, ECMO seems to have gotten to be popular again. And so this is a timely presentation on ECMO success after an electrifying near drowning, to be presented by Arthur Grimes from the University of Oklahoma.
Before we move on to Arthur, there are several questions in the chat, moderator.
Sorry about that. Why use a capture permanent tack when using absorbable mesh?
That is an excellent question. I think from this standpoint, this could have been surgeon preference. It wasn't between the choices of mesh. We did not trust that the biologic would be able to hold. We also did not trust that a permanent mesh would be infection free. But we did want to make sure that this mesh did not move. It did not roll. It would not migrate out of place, given the fact that this was a traumatic hernia, and we were putting in basically a long-term absorbable mesh. So that was, I think, the idea behind using a permanent tack on an absorbable mesh. Long-term, that there's something we will definitely look into is there any difference between putting in absorbable tacks with absorbable mesh versus non-absorbable tacks into absorbable mesh?
Did you use ICG to evaluate bowel perfusion?
We did not. We grossly examined the abdomen with the camera, but that is a very good adjunct, I think, going forward, especially if we're already in with a robot and we can use the Firefly function to look for perfusion in the setting.
And when did you do this case? Is your robot available 24 hours a day?
That's a very good question too. So this case was done the following day after his initial, after he sustained his initial trauma. But the robot is available usually 5 days a week during the work time. So we tend not to launch any robot cases during the weekend, and it does need to be booked ahead of time. But this patient got very lucky that the robot was free for us to be able to repair it this quickly during his hospital stay.
All right, clearly I need some help with this whole virtual thing. I've already had my son help me with one thing, but there's one other question here.
Okay.
Do you have any experience with delayed repair of these Do you have any experience with delayed repair of these types of hernias?
We do not, that I know of. I don't know how many people have experienced or how many cases of a traumatic failure there are, but we in our institution, we have never tried to do this delayed.
Great. All right, that is it now. So now we'll move on to Arthur Grimes talking about ECMO and electrifying near drowning.
All right, can you hear me? Is that good? All right, my name is Arthur Grimes. I'm a general surgery resident at the University of Oklahoma, and ECMO success after electrifying near drowning. We have nothing to disclose. We presented a 31-year-old male who was electrocuted in a Riverwalk waterway in Oklahoma City. The patient attempted to save a man who fell into the Riverwalk and was electrocuted by a small light pole that fell in with him. And you can see in that bottom right hand corner of the picture, an example of the light pole that fell into that waterway. He was submerged for approximately 5 to 6 minutes, and upon retrieval from the water, he was pulseless and required 2 rounds of cardiopulmonary resuscitation and chemical cardioversion to obtain a spontaneous circulation. His initial vitals upon presentation to us, heart rate was 112, respiratory rate 22, blood pressure was okay, he was satting 99%, his temperature is 35.8 degrees Celsius. He's very acidotic with a 6.82 pH, his PO2 562, CO2 52, bicarb 9, and base deficit negative 26. His lactic acid was 18.2 and troponin 15.88. As presentation in the hospital, there was concern for anoxic brain injury with the presence of myoclonus. This myoclonus lasted somewhere between 60 and 90 minutes and eventually resolved with a midazolam drip and neuromuscular blockade. A hypothermia protocol is initiated by the medical team for 24 hours, along with lung protective ventilation and broad spectrum antibiotics with piperacillin and tazobactam. Fortunately, subsequent electroencephalograms showed no seizure activity, and within a few days of hospital admission, he was communicative to his family while on the ventilator. These are his chest x-rays from the first 2 days, showing worsening bilateral pulmonary infiltrates. But by hospital day 4, the patient developed worsening hypoxia. He was on maximal sedation, neuromuscular blockade. He had increasing ventilator requirements. He was having desaturations to 60%. His PO2 was 65 to 73, and his PF ratio was around 65. His vent settings were set at PEEP of 15, FiO2 between 85 and 100, and he was on inhaled nitric oxide. These are his chest x-rays on day 3 and day 4. The surgical team was consulted for ECMO cannulation at that time. Fortunately, he had a respiratory ECMO survival prediction score of +4, which is a risk class of 2, showing that he would have a 76% in-hospital survival rate with ECMO. But his Murray score was 3.5, with 3 having a 80% mortality risk. These are his x-rays of cannulation with right internal jugular and right femoral vein cannulations. He was maintained on rest ventilator settings throughout his extracorporeal life support. His INO was weaned by day 3. His neuromuscular blockade was weaned by day 4. We were able to decannulate him by day 5 with his chest x-ray from that day showing improvement of his infiltrates bilaterally. He was discharged to home with family. He had very minimal deficits, a little bit of memory loss of the event, but other than that, he was very functional. He followed up in our clinic, doing well at home, but he was from a state other than ours, so he is following up with a different university. So beyond that, I don't have more information on him, but as far as I know, he's doing well. So this case highlights the multifactorial difficult clinical problems that may arise with near drowning. It's important to remember that not all water-related deaths can be presumed to be from the drowning, but maybe weather, temperature extremes, drug intoxication, or even natural disease. In our case, we were dealing with electrocution, and that required aggressive fluid therapy. With electrocution, there's potential for tissue damage causing myoglobinemia, electrolyte abnormalities, and eventual kidney injury. Fluid therapy that's required may exacerbate lung injury in drowning victims that often leads to ARDS. With drowning, the lung injury occurs because there's an involuntary activation of the laryngeal nerves leading to a protective mechanism of laryngospasm. And with the obstruction caused by laryngospasm, there's prevention of oxygen exchange and carbon dioxide exchange, and there's lung damage from an ischemia reperfusion injury. And the important thing is the functional outcome of the patient with near drowning mostly lies in the extent of their anoxic encephalopathy. The pneumonia found in this patient cohort, most studies actually don't recommend prophylactic antibiotics. And the 2019 Wilderness Medical Society practice guidelines for treatment of drowning points out that pneumonia may be difficult to diagnose in these patients because of leukocytosis and fever that may occur with the stress demargination and inflammation caused by water in the airways. And this is a picture of the canal at a different time when it was being cleaned out, just to kind of show what's in that water. Our patient was started on broad spectrum antibiotics by the medical ICU for concern for aspiration pneumonia on admission. His BAL on hospital day 2 showed only scant and light growth of bacteria, and his BAL from hospital day 6 was more borderline with E. coli at 10 to the 4th colony forming units. So in conclusion, there's a multitude of factors that contributed to this patient's hypoxic respiratory failure requiring ECMO. He had hypoxic encephalopathy, cardiac arrest, ARDS, and rhabdomyolysis with AKI. Likely the lung injury was from the drowning and the large volume resuscitation because of his electrocution causing severe ARDS. In this case, kind of highlights that veno-venous ECMO has successful outcomes in appropriate drowning victim candidates, and that's something that's being looked at in other institutions. Thank you.
Great, thank you. Very nice presentation. People are clapping for you here. You probably can't hear that. This paper is now open for discussion. So I'll read you from the thing here. How many patients of non-cardiac etiology does your center place on ECMO? How many trauma patients would be candidates?
Unfortunately, I don't know the number of the amount of patients that we've placed on ECMO without cardiac causes. As far as I know, we have cannulated one patient that has COVID currently. In fact, she was pregnant. So that was very recently. So I don't know her outcomes yet. And that's about all I know so far with the ECMO. ECMO is relatively new at our institution, and I don't have those numbers.
Another question, were other methods of ventilation used besides nitrous oxide, such as APRV, tried before going to VV ECMO?
No, I don't believe that they were. And in fact, the other thing that was interesting, they had not prone the patient. It was kind of acute desaturations that led them to kind of be backed into a corner with the hypoxemia and call us for cannulation.
Another question here. If this is a traumatic event, i.e. electrocution, why was he in the MICU and required surgical consultation only for cannulation for the ECMO?
I don't know the exact reason with the initial admission, but I don't believe he had any signs of trauma besides the electrocution. I don't know who made that decision, but we got involved and handled the rest of his care.
I think that if these people were here live, they would probably challenge you about that one. Again, you had nothing to do with that. So, Scott Wilhelm.
Very nice presentation. I was a little impressed with how quickly the chest X-ray improved. Really only like 5 days after you had cancer on ECMO. Is that something that's more typical of drowning events? Because the multi-system organ failure, ARDS, infection, or other reasons, most of the time the chest X-ray really lags. And I'm surprised you got off as quickly as you guys got off.
Could you hear that at all?
No, sir.
So he said that his chest X-ray got a lot better really quick. Is that typical for drowning victims? Because most times when we see people with ARDS for other reasons, it doesn't seem to improve so quickly.
Could be the case, and right. Usually the chest X-ray findings are very delayed. Could be.
Dr. DeBoer, did you have a question? You probably didn't hear that either, right?
No, sir.
So now with COVID, we've been using dexamethasone. Is there anything that you know of in using dexamethasone in these drowning victims?
No, sir, I don't. For my research on this topic, I've not seen that specifically for drowning. Drowning is kind of a nebulous thing that people are trying different modalities for treatment. So I don't know.
Another question. I'm sorry, I can't. Did you guys do bronchoscopy, or were these BALs done trans endotracheal tube?
I believe they're a trans endotracheal tube for those.
And then a question from the virtual participants. Which team is responsible for the care of burn patients in your facility?
We are starting a burn program at our institution. We have another facility in town that takes more serious burns at the time of this. But it will be trauma from this point forward.
All right, great. Thank you very much.
Sure. Thank you.
Next presentation, free air up there, tension pneumothorax from gastric ulcer perforation by Dr. Jamil Abu Hanna from the University of Illinois, Peoria.
Can you hear me okay?
Yeah, perfect.
Great. All right, thanks for the opportunity to present here today at Midwest Surgical. As you said, the title of my presentation is Free Air Up There, Tension Pneumothorax from a Gastric Ulcer Perforation. I have nothing to disclose. So as we all know, PPIs and H2 blockers have made gastric ulceration and perforation uncommon. And even more rare is the incidence of gastric perforation within a paraesophageal hernia. These have historically been noted to have significant morbidity and mortality. And the patient presentation is variable, anywhere from tension pneumothorax to pneumonia to peritonitis. There's a paucity of literature regarding this complication, especially in the last 20 to 30 years because of PPIs and medications. And because of that, there's no real surgical guidelines in the emergent setting for that. But it provides me with the opportunity to present a spectacular case in surgery and talk about our findings. So our patient is a 79-year-old female. She was a Jehovah's Witness. She presented to an outside hospital emergency department with fatigue and syncope. Her past medical history is significant for hypertension. For medications, the only thing she really took was NSAIDs every day, especially as very recently to her ED visit because she's the sole caretaker of her daughter, who's a mentally disabled person. And so she had a lot of back pain because of that and was taking NSAIDs multiple times a day. Her initial vitals in the emergency department were concerning for hypoxia, hypotension, and tachycardia. And her labs were significant for a leukocytosis of 14,000 and a lactic acidosis of 7.5. In the next part of their workup, they obtained a chest x-ray, and you can see here she has a significant tension pneumothorax. You can see the tracheal deviation and a large left pleural effusion. So they, rightfully so, placed a 32 French chest tube and about 1.5 liters of purulent foul-smelling fluid came out. She was transferred to our medical ICU at our tertiary center for treatment of presumed pneumonia and sepsis from that. The following day, as you can see, this is a representative image of her CT scan of her chest. They got this the following day and noted concerns for gastric ulcer perforation with extravasation of oral contrast into her chest. So at this point, they called us and we saw her that evening. We consented her for an exploratory laparotomy. And when we first got in, we noted 2/3 of the stomach herniating into the chest. As we kind of peeled off the stomach gently, it was pretty adhered to the pleura. We noticed a pleural defect and then a large 9 by 5 centimeter ulcer of the greater curve. The hole is so big, we were actually able to look in the stomach and noted multiple small clean-based ulcers kind of consistent with NSAID pathology. We washed out the chest through the pleural defect. We resected the margins. And then because of the inflammation and how sick the patient was in the operating room, we didn't want to spend too much time reducing the stomach at that point. We closed the perforation in 2 layers with an omental patch, and then we placed a Witzel J-tube for further enteral feeds. Postoperatively, her care was complicated by atrial fibrillation and AKI that improved, recurrent empyema that was eventually drained by IR, and then acute blood loss anemia. But of course, we couldn't transfuse her because of her religious beliefs. She was discharged to a nursing facility on postoperative day 24, and her pathology was concerning for necrosis with ulceration, and she had no neoplastic changes or H. pylori in her immunochemistry. So this kind of brought up an interesting discussion preoperatively and intraoperatively while we were doing the case. And kind of the big things that we gleaned from this was the approach. So whether we should do a laparotomy versus a thoracotomy, what to do once we got in there. So do we reduce it? How do we repair this? And do we do a fundoplication if we even can, or is that even indicated? And then of course, enteral access, how we would obtain that. So traditionally, incarcerated paraesophageal hernias historically were fixed with either a thoracotomy or a laparotomy, but this has kind of been replaced by laparoscopy. And kind of the benefit from a thoracotomy is that these large incarcerated hernias with large amount of hernial contents can be accessed a little easier from the chest. If the patient's been there for a while, you can kind of take it down and wash out the chest well. But the problem is with a lot of these patients, I've seen many of the case reports for this kind of problem are older, and they may not tolerate a thoracotomy incision. They also may not tolerate single lung ventilation intraoperatively when they're septic. So the laparotomy, which is what we chose, the benefit, of course, is it's more tolerable. You have access to the abdomen for other procedures like a J-tube, but as was the case in ours, it was kind of difficult to reduce the stomach, especially in the emergent setting. So again, we chose laparotomy. She was older. She's a Jehovah's Witness. We didn't want to put her at risk for further bleeding with a thoracotomy, and she was very septic. And so the question is, what to do once you actually get into the abdomen. In terms of elective incarcerated hernia repairs, typically the tenets of surgery are to dissect and reduce the hernia, mobilize and lengthen the esophagus, close the hiatus, and then plus or minus a fundoplication depending on if it's indicated. But in these patients, when you have a perforated ulcer and have a lot of infection in the chest or in the abdomen, it's a little different. And the surgical management differs significantly. And so if you look at the case reports that have been written over the last 20, 30 years for this, they all kind of approach it differently. But I think some of the things that we glean from our literature review is that they always will excise the margins, of course, to look for some kind of cancer. Many deferred the excision of the sac and kind of dissection into the mediastinum because you don't want to contaminate the mediastinum from all that fluid. You wash out the chest or the abdomen wherever the perforation is. And then there are some cases where they narrow or close the hiatus, and that seemed to work for some cases, but others would have postoperative complications such as a suprahiatal abscess or empyema, and it actually there was a couple cases where it caused the patient's death actually, and they had to go for re-exploration. Some would perform a stam gastrostomy and place a G-tube directly through the small hernia and perform a pexy if they were able to, if the stomach was reduced. And then finally, multiple of the cases had a jejunostomy tube placed for access for enteral feeds versus a gastrostomy tube. So in conclusion, gastric perforation within a paraesophageal hernia is rare, but it's complex. The management differs significantly from an elective repair. I think, again, if we were to do this again, we'd again resect the margins of the ulcer, close it primarily, reduce the stomach if we're able to, and then again, get enteral access feed. I think that's very important. And I think it kind of brings up the question, I think the recommendations have changed over the years for asymptomatic paraesophageal hernias, but you may want to consider repairing them in the healthy elderly patients who can tolerate this kind of surgery just to avoid this deadly complication. So with everything in surgery, increasing success of medical treatment typically prevents this type of spectacular surgical problem, but I was very fortunate to see this case in my residency, and I'm happy about that. Here are my references, and I'd be happy to answer any questions.
Thank you. Thank you very much. There is one question in the audience here.
Have you done any X-ray contrast study before discharge to see if this hernia reoccurred? It did not reduce the herniated sac on the chest. This hernia is not notoriously back.
Did you hear that?
Something about an X-ray, but
Did you do a contrast study of this patient before she was discharged? Because if that's not done and this hernia has not been reduced, that they tend to recur.
yeah, I mean, I think it's a fluid collection for empyema because we were concerned about that, and it got drained by IR. But I think it's definitely something she needs to consider. We weren't able to reduce the stomach, so I mean, it's definitely potentially still there. Just because of how sick she was.
A couple of questions from the virtual audience. Dr. Schroeder, a perforated ulcer will cause pneumoperitoneum, but not tension pneumoperitoneum unless inflated by a gastroscope. So why do you think the pneumothorax became a tension pneumothorax?
I think, so what happened is it likely either fistulized to the pleura, and then once it perforated, it allowed for the tension pneumothorax to happen. There's a couple case reports that mention that that's a possibility or a theory as to why that can happen. And I think it's probably related to that because it was stuck up on the pleura. And so I think with just bad luck, that's likely what happened.
Dr. Mammon asked, what criteria do you use to determine if you want to repair an asymptomatic paraesophageal hernia in healthy geriatric individuals, something you alluded to in your discussion there? To avoid the risk of perforation, do you recommend that these individuals take acid-reducing medications?
Well, to answer the second question, I think the acid-reducing medications would be if they have, symptoms of peptic ulcer disease. I don't know if necessarily putting them on that. You'd have to have a criteria just for the asymptomatic patient for that. I don't think there's a criteria for that. It's generally not recommended. The risk of performing elective paraesophageal hernia, I think, is greater than these people that you can watch and wait, for example. But I do think it is something to just consider if a patient's very healthy and they're elderly and they've got a large paraesophageal hernia. You know, I don't think there's necessarily a guideline to do that, but I think it's just something to keep in consideration.
Was there a volvulus involved, a gastric volvulus, or was this just a perforation?
Just a perforation.
All right, great. Thank you very much. We will move on to the next spectacular. Can you hear the clapping?
I heard some clapping, yeah.
All right, good. There's been clapping for each of the presentations. It's hard, I think, for the.
I'm just down the hall, so I can also hear it down there.
Oh, okay. There you go. Spectacular problem number 4. Fulminant gastrointestinal bleeding is a late complication after isolated pancreas transplant, to be presented by Tara Berry from the University of South Florida.
Can you guys hear me okay?
Yes.
Great. Let's get started.
You're not right down the hall as well, are you?
No, I am in Tampa with COVID, actually.
Good, because
But-
otherwise,
Glad to be joining you.
otherwise we would have told you that you had to quarantine yourself for 14 days before we let you in here. But all right, great.
I know. Good evening. My name is Tara Berry. I'm a PGY4 general surgery resident at the University of South Florida. Thank you for the opportunity to present this case today. The authors have no disclosures. This is a 42-year-old female who presented complaining of 1 month of melena that progressed to 1 week of hematochezia accompanied by nausea, weakness, and dizziness. She denied pain with bowel movements, had no family history of colon cancer, and no prior colonoscopies. She endorsed intermittent crampy abdominal pain and daily NSAID use for 1 week. Her hemoglobin was 11 2 months prior to presentation and 6.7 on admission. It was responsive to transfusion. Pertinent history includes type 1 diabetes. She had an isolated pancreas transplant to the right common iliac artery and inferior vena cava with a duodenojejunal anastomosis in 2009 at Northwestern. Despite immunosuppression with Prograf and Myfortic, she experienced rejection of her transplant 6 months prior to presentation and was requiring exogenous insulin. Initial EGD on hospital day 1 showed no active bleeding. Colonoscopy on hospital day 3 showed red blood throughout the colon, scattered ring-like mucosal lesions, and dusky mucosa in the rectosigmoid and descending colon. These were biopsied. Repeat EGD with push enteroscopy on hospital day 3 showed red blood in the midjejunum with a long clot extending 100 centimeters from midjejunum to proximal ileum. No source was identified and the distal extent of the clot was marked. The clot was not able to be washed and care was taken not to dislodge it due to concern for bleeding. Additionally, a lesion was noted in the midjejunum and there was no evidence of active bleeding at this time. Interventional radiology performed multiple mesenteric angiograms that did not demonstrate active bleeding. CT of the abdomen and pelvis showed an atrophic native transplanted pancreas replaced by cysts and calcification and also showed no source of bleeding. Of note, a selective SMA and celiac access and IMA arteriograms were performed, but the aorta and iliac system were not studied at that time. The pancreas graft was not considered as a possible source of her bleeding. She had an abrupt change in her clinical course with recurrent hematochezia and hematemesis, multiple nasogastric tubes evacuating liters of blood from her upper GI tract. She had cardiopulmonary arrest multiple times, requiring massive transfusion protocol and vasopressor support. After 2 subsequent cardiac arrests, she had return of spontaneous circulation with ongoing hypotension despite the massive transfusion. Her rapid TEG was notable for an LY30 of 15.1%, highlighting the profound coagulopathy. She required TXA. She was in critical condition and returned to IR after the CT scan was reviewed again and was notable for a right common iliac artery pseudoaneurysm. The primary team did not consult the transplant service until the morning after the pseudoaneurysm had ruptured. Right femoral arteriogram revealed massive extravasation from the ruptured pseudoaneurysm off the mid aspect of the right CIA, likely related to erosion of her arterial conduit from the transplant pancreas. Arterial extravasation entered the GI tract via the pancreas transplant at the duodenojejunectomy. Erosion of her arterial conduit was most likely occurring when she returned to insulin therapy and her immunosuppression was weaned, causing ischemic necrosis, subsequent infection, and erosion. A covered stent was placed at this time to temporize the bleeding. However, this wasn't a permanent solution due to the high risk of infection given the proximity to bowel. She required intensive care for ongoing coagulopathy, altered mentation, and liver dysfunction. So from her index case, she had this isolated pancreas transplant to her right common iliac artery and IVC with a duodenojay anastomosis. When clinically stable, she returned to the OR for transplant pancreatectomy and small bowel resection with primary anastomosis at the site of the aortoenteric fistula. She underwent concomitant resection of the right CIA and covered stent graft. A paneled saphenous vein graft was used for reconstruction, and a bare metal stent was placed from the common to external iliac artery to ensure adequate flow. She made a full recovery and was eventually discharged home. So late GI bleeding after pancreas transplant is a rare but potentially life-threatening complication. Pseudoaneurysm has a reported incidence of 1.4 to 8%, with a rupture or aortoenteric fistula being even more rare. It can be seen with both functioning and failed allografts ranging from greater than 10 years, either months to 10 plus years after transplant. The pathophysiology is thought to be related to inflammation from the transplant pancreatitis. Functioning allografts can be salvaged with the use of selective embolization. This case was unique because the patient had this isolated pancreas transplant and the bleeding occurred 10 years later. And rather than using a staged approach, as is discussed in the literature, we were able to perform the definitive management of the vascular complication being addressed simultaneously with the explant of her remaining pancreatic allograft tissue. This allowed for expedited recovery. So acute GI bleeding from arterioenteric fistula is definitely rare but life-threatening. Expedited diagnosis is essential, including early involvement of the transplant team. Stenting can be useful to temporize bleeding, but is not definitive management in the setting of infection. And in this patient, I think a detailed past medical and surgical history may have facilitated earlier diagnosis. I would be happy to take any questions.
Thank you for that presentation. There is one question in the audience here. Did you hear that?
No.
Why did she require a bare metal stent across the saphenous vein graft?
They weren't happy with the flow when they looked at it after they finished the saphenous vein graft, and they wanted to make sure that it remained patent.
Any other questions in the audience? All right, well, thank you very much. I know that it was not the easiest for you to present, but we appreciate you presenting, and I think you're up again on Tuesday, so we will hear from you again Tuesday.
See you then. Great.
Right.
Thank you.
Good. Thank you very much. Sorry. I need my son back here. I did not unmute. So the next case is a rare case of an invasive anterior mediastinal teratoma by Kurt Peening from the University of Illinois, Peoria.
Kurt seems to be having some technical issues. Can we move on to Anna and see if I can help Kurt get his technical issues taken care of?
We definitely can do that. So spectacular case number 6, an unexpected second pheochromocytoma in pregnancy by Anna Quian from Metro Health Medical Center. Looks like she's a medical student.
Hi everyone, my name is Anna Kian. I'm a 4th-year medical student at Case Western Reserve University, doing rotations at Metro Health Hospital. So I'm presenting a case of an unexpected second pheochromocytoma in pregnancy. We, the authors, have nothing to disclose. So this was a 30-year-old female with multiple endocrine neoplasia type 2A with a C634R mutation in the RET proto-oncogene. She presented for a routine prenatal visit at 15 weeks of pregnancy. Her symptoms that she reported were headache, nausea, feeling increasingly warm and anxious, and she attributed these to her pregnancy. Her headaches occurred in association with morning sickness. Her family medical history is significant for her mother, maternal grandfather, uncle, and 3 cousins who all had MEN2A syndrome. At this visit, her blood pressure was 130/80 and her heart rate was 90. Her past surgical history is significant for just 11 months prior. She had a left laparoscopic adrenalectomy for multiple pheochromocytomas. After that, her surgery, she had normal post-op metanephrines. Remotely, she's already had a total thyroidectomy with central neck dissection for medullary thyroid cancer and a total parathyroidectomy for hyperparathyroidism. So the MEN2A syndrome is characterized by an altered expression of RET proto-oncogene leading to increased tyrosine kinase activity. Pretty much all of these patients will develop medullary thyroid cancer. About 20 to 30% will develop hyperparathyroidism, and about 40% will develop pheochromocytoma. The pheochromocytomas associated with this condition are usually benign, multicentric, bilateral, and associated with diffuse nodular hyperplasia. Of those MEN2A patients who develop a unilateral pheochromocytoma, it was found that about 30% of them will develop the contralateral pheochromocytoma at an average of 9 years. Our patient in particular had this C634R mutation, and this is associated with a younger age of penetrance for pheochromocytoma. So in about 60% of people with the C634R mutation, they develop pheochromocytoma by age of 40 years, compared to 25% of people with other C634 mutations developing pheochromocytoma by 40 years. Lang et al. Also found that the cumulative risk of bilateral pheochromocytoma reaches almost 100% in 67 patients with C634 mutations. Her obstetrician elected to obtain screening metanephrines for her at her prenatal visit. Her plasma metanephrines and normetanephrines were elevated at 79 and 209 respectively, and her 24-hour urine metanephrines and normetanephrines were elevated at 448 and 663 respectively. Based on these elevated metanephrines and her history, she underwent MRI to look for further imaging. Her MRI revealed a 1.5 centimeter nodule with mild T2 hyperintensity in the right adrenal gland that you can see here, which compared to this MRI from her 1 year prior, you can see she had a normal adrenal gland in that. The problem with pheochromocytoma in pregnancy is the high maternal and fetal mortality rate, ranging from 8% for maternal mortality and 17% for fetal mortality. The problems in this are attributed to stroke, MI, tachyarrhythmias, premature labor, and several delivery complications. if the pheochromocytoma remains during delivery. The treatment for pheochromocytomas in pregnancy is surgical resection with adrenalectomy laparoscopically, ideally in the second trimester, to avoid impacting organogenesis. Prior to the surgery, the patient should undergo 10 to 14 days of alpha blockade. So for our patient, we started her with 10 days of alpha blockade with doxazocin, started at 1 milligram and increased to 2 milligram. We typically use terazosin for its short-acting effects. However, due to its category Class C for pregnancy, we elected to use doxazocin instead. In addition, we made sure to adequately hydrate the patient, giving her a 1 liter bolus preoperatively, and we also checked fetal heart tones pre and post-operatively. During the operation, we ensured having an arterial line and central venous access for blood pressure monitoring, as well as medications and fluid resuscitation. In the OR, we wanted to have nitroglycerin ready for increases in blood pressure, esmolol ready for tachyarrhythmias, and phenylephrine ready for hypotension if she was not responding to volume resuscitation. During the operation, she had blood pressures ranging from 74 to 38 at her lowest, which transiently happened after the ligation of the right adrenal vein and responded to fluid resuscitation, and the highest blood pressure of 163/96. During the operation, she did not need significant blood pressure or arrhythmia management during surgery. On her pathology, her right adrenal gland was found to have 3 multifocal pheochromocytomas, measuring 1.5 centimeters, 1.5 centimeters, and 0.7 centimeters. The margins of the excision were negative. On follow-up and after the surgery, she was able to go home on post-op day 1 with Florinef and hydrocortisone for her adrenal insufficiency. At 3 weeks, her plasma metanephrine were normal. And at 39 weeks, she underwent induction of labor in the setting of gestational diabetes with steroid stress dose during labor. She had a successful spontaneous vaginal delivery without complications. And here are references.
That was a very nice presentation. There is a question here in the audience. I'll have him say it and then I'll repeat it to you because no one can hear.
Very nice presentation. One question I had for you, you said that she had her laparoscopic remodeling done on the opposite side about 11 months before. You said she had a follow-up set of plasma metanephrine that was negative. What was the timing of that in terms of after her surgery? I'll stop there and let Dr. Bell relay that.
He also said that you did a very nice presentation. So that's the first thing. Well, it's important for you to hear that. You're just a medical student, right?
Thanks.
But he said that you mentioned that she had a laparoscopic adrenalectomy on the other side before her pregnancy, and that she had normal metanephrines done post-operatively. But what was the timing between when the surgery was completed versus when that lab value was done?
So the post-op metanephrines from her first surgery, so her first surgery was in January of 2019, and her post-op metanephrines were acquired about 3 to 4 weeks after her surgery. Her second time that she got metanephrine, so when she presented for her prenatal visit, that was in December and January of 2019 and 2020 respectively.
And any other laboratory tests that you're aware of that might be more sensitive for metanephrine for picking up a recurrence of pheochromocytoma, especially in a familial patient like this?
Are there other laboratory values other than metanephrines that you are familiar with that would have been helpful in picking up another pheochromocytoma, especially in a patient with a familial syndrome like this?
Well, there is a radiotracer that you can use to check for pheochromocytomes, especially if they're not in the adrenal glands. However, that was not an option for this patient, or not recommended because she was pregnant.
Just one other thing to think about is chromogranin A levels oftentimes can be more sensitive for the early detection of recurrence of the pheo, so there's something to think about, but really nice job taking good care of this patient.
So chromogranin A levels, especially in familial patients, is helpful in picking up early recurrence or other pheochromocytomas in these familial patients. And he once again said that you did a very nice presentation and took very good care of this patient. It's just, and now there's a lot of clapping. You're not down the hallway, are you?
No.
No, okay. All right, there is let's hold on a second here. That is it for the questions. Thank you very much. And in years to come, we look forward to you presenting as a resident here at the Midwest Surgical Association meeting.
Thank you.
All right, our next presentation is back to number 5, a rare case of invasive anterior mediastinal teratoma by Kurt from the University of Illinois in Peoria.
Thank you, and I apologize for the technical difficulty earlier. This is a case of a rare invasive anterior mediastinal teratoma. My name is Kurt Peening. This is a case that I did with the chief resident, Dr. Alyssa Maurer, and one of our attendings, Dr. Richard Anderson. We're all located at the University of Illinois in Peoria. I have nothing to disclose. So the patient is a 22-year-old woman who was seen in the emergency department with shortness of breath and chest wall pain. Imaging at the time revealed a 9.1 centimeter right upper lobe mass that was containing calcifications, as well as a right lower lobe pneumonia with an associated effusion. She was admitted to medicine, and interventional radiology was consulted at the time for thoracentesis of the pleural effusion and biopsy of the mass. The effusion, while yielding originally gram-negative rods, didn't actually demonstrate any bacteria on final culture, and no malignant cells were noted in the mass despite multiple biopsies. She was treated with IV antibiotics at the time and had improvement in her symptoms, so she was discharged with plans to follow up imaging in the future and have her follow up with ID as well. Follow-up imaging revealed continued right upper lobe mass, as well as now a loculated pleural effusion in, next to the right lower lobe. The plan at that time per infectious disease was to continue her IV antibiotics and again repeat imaging with plans to consult thoracic surgery in the interim. So again, she did receive another CT, this time showing a continued mass, and presently it was concerning for possible compression of the right atrium, despite her having any worsening symptoms. She was seen by thoracic surgery, and the plan at that time was to proceed to the OR for resection. So a right-sided video-assisted thoracoscopic surgery was planned with the noted possibility that we might convert to an open thoracotomy. This was to assure that we would be able to not only reach the right upper lobe mass, but as well as investigate the right lower lobe loculated effusion. So the thoracic cavity was entered, and upon entering it, dense fibrous adhesions were noted between the lung and the thoracic cavity. So the decision was made to proceed to an open thoracotomy and able to fully and safely dissect out all the structures that we needed to. We first proceeded to investigate the inferior lateral mass. This was noted to be adherent to the diaphragm and was mobilized, albeit with some spillage of purulent fluid and sediment. Cultures were then taken of the fluid, and the tissue was sent to pathology for frozen sections. The pathologist returned and said that he noted some fibroepithelial cells, but was unable to tell if there was any malignancy present. We then turned our attention towards what now appeared to be an anterior mediastinal mass. This is it open here on the left, and you can see some very sedimentous material, as well as some hairs if you look closely here. I apologize, these are all iPhone photos. So once we inspected the mass, we noted that it did grossly involve the pericardium. So we decided at that time that we would purposely open the mass in order to gain access to its posterior wall and identify all of the critical structures involved. Upon opening the lesion, cheese-like substance, hair, and multiple types of tissue were identified consistent with a teratoma, as you can see on the previous picture. The mass was then mobilized, and we attempted to remove it en bloc and dissect it off of the right atrium. Unfortunately, a small hole in the right atrium was identified, and this was quickly repaired with pledgeted proline suture. You can see that in the center of the photo here on the right side. The remainder of the non-invasive mass was then debulked as much as we possibly could, and the pericardium was then closed after the thoracic cavity had been copiously irrigated. Post-operatively, the patient recovered quite quickly and was discharged without complication. Final pathology returned as benign mature cystic teratoma on both of the cystic structures. The patient's further treatment was then discussed in a multidisciplinary tumor board, and the decision was made to refer her to a proton therapy center for potential radiation due to the incomplete resection of the mass and inability to rule out any malignant transformation in the remainder of the mass on the heart itself. Here are my references, and I will take any questions.
Thank you very much for that nice presentation. This paper is open for discussion.
Did you receive proton therapy in a prophylactic manner?
Do you know if she received proton therapy in the prophylactic manner?
So unfortunately, shortly after the referral was made, COVID hit. And so she was lost to follow-up for several months. The last documentation that we have in our system is that she had been reached out to and answered back and apologized that she hadn't followed up yet and that she would be reaching out to Northwestern for the proton therapy. This was back in May.
I think that's it. Thank you very much.
Thank you very much, sir.
There's a lot of clapping. All right, the next paper for presentation is Evisceration after abdominal perineal resection by Kyle Harris from Wright State University.
Good evening, everyone. Can you hear me okay?
Yes, we can.
All right. Just want to say thank you for the opportunity to present this spectacular case. Thank you, Dr. Eke, for allowing me to do this. So this is evisceration after abdominal perineal resection. We have nothing to disclose. So a little bit of background. Reported perineal wound complications following APR range anywhere from 14 to 80%. Now this wide range is not surprising considering the patient population, the indications, the underlying patient disease, or even the use of neoadjuvant, adjuvant, radiation, and now even multiple repair techniques all have an influence on how wound heals. So wound dehiscence is actually quite common after APR. Most studies reported anywhere from 10 to 30%, even higher in some studies. But wound complications are also associated with increased or decreased survival and increased morbidity and mortality. Usually that's been attributed to delay in adjuvant treatment. Now, perineal bowel evisceration is particularly rare. There's very few case reports that I was able to find and very few recently. So this is why we're presenting a spectacular problem here. So the objective of this study was really just to heighten awareness of this complication and even suggest a corrective procedure. So this was a 73-year-old female with a history of a laparoscopic APR with flat perineal closure for anal melanoma 1 year prior to her presentation. Now, when she presented to our emergency room, her bowel had eviscerated from her perineum. She arrived hemodynamically stable, appeared under-resuscitated, but otherwise okay. Bowel did appear compromised. She recently removed from Texas. She had not established with any general surgeon that we're aware of, and really had an unknown medical history. She had never been to our hospital before. Now, upon further evaluation and gathering her history, she did report she had a chronic perineal wound. She's been undergoing local wound care for small area wound dehiscence and drainage for several months. She was being established with a plastic surgeon who had planned, I guess, definitive repair in the following month. I'm not sure if she'd actually been evaluated by the plastic surgeon yet. She also reported a history of adrenal insufficiency requiring steroid replacement after adjuvant treatment, and she was a non-smoker. So on presentation, this is what her bowel had looked like. You can see her small bowel colon had completely eviscerated from her perineal wound. Her bowel was quickly evaluated and covered with saline soaked gauze to keep it from desiccating. She was undergoing resuscitation as she went to the OR. Now, in the operating room, we had placed her in the lithotomy position so we could, in case we needed to, we had access to her abdomen if we had to do a laparotomy. However, upon further evaluation of the bowel did appear viable. There's no frank necrosis or occult ischemia that we could see, and the bowel was actually able to be returned intra-abdominally through the perineal wound, which had completely dehisced. So the wound was actually closed, primarily the perineal wound, in layers, followed by a stratus mesh placement in onlay fashion. And then the skin was closed over that with interrupted nylon and vertical mattress fashion. Here you can see the skin closure and the ultimate result. So no bowel had to be resected. We didn't have to go perform a laparotomy. She did remarkably well. She was discharged post-op day 3 with few complications. She was eating, her pain was well tolerated, and her ostomy function had returned to normal. Initially, she had an ileus, but then started returning to normal. And then upon further follow-up, her wound continues to heal. She's doing well, and no post-operative complications, really. So in conclusion, there have been very few instances of reported perineal wound evisceration after an APR. Now, any case reports that you can find are very old and dated, and usually the repair involved laparotomy, incision, running the bowel, and even a bowel resection. So this is a described technique. It's very unique. And was this the best repair? It's hard to say because this population has not been well studied, but we did have a good outcome. So this is just one way to repair this type of wound to keep in your armamentarium. Now, what's difficult to say is what led to this complete wound failure. Now, her flap closure, we're not sure. It looked like a gracilis flap closure, but we don't have those medical records. But one can speculate, the history of her steroid requirement and possibly her adjuvant treatment may have led to her wound failure, but it's really hard to say. I'd like to welcome any questions or comments. Can you hear me?
Sorry.
There you go. Now I can hear you.
So you wouldn't have been able to hear it anyway. So you described an onlay technique using stratus. Post-operatively, did you have any problems with wound complications or seroma formation?
No seroma formation. The skin took time to heal, but really no post-operative complications. We left the interrupted nylons in for an extended period of time, more than 2 weeks, but they were eventually taken out and her wounds stayed together without drainage or seroma, no.
There's another question here. So the question is maybe one you can't answer because you said you didn't have the records, but anal melanoma in general has a poor prognosis.
Yeah.
And so do you know anything about this? And do you know anything about what sort of treatments you may have received, including immunotherapy, radiation, et cetera?
No. So unfortunately, no. My understanding, it was immunotherapy, whether it was like interferon or one of your PD-1 inhibitors or even CTLA-4 inhibitors, we're not sure. Based on her side effect profile, one could think of with the adrenal insufficiency, you may think it could be one of them. I think your voice is what it's called, or the CTLA-4 inhibitors, but I can't confirm that. Unfortunately, we don't have those surgical records either.
So this was a year out, right? She had seen
Correct.
a plastic surgeon. I presume the plastic surgeon was at your institution?
Not our institution, is an outside hospital. So it sounds like she was either going to be seen by a plastic surgeon with plans for definitive repair, but we don't actually have those records. That's just kind of what we were told. She was being seen for wound care. I think the wound care had referred her to a plastic surgeon. I don't think she was actually seen by that plastic surgeon yet.
Because I would think as you did your research into evisceration after perineal wound, APRs, or any sort of perineal procedure, I think that you would have found that most of these happen in the short term rather than in the long term.
Correct. Yep. And most were. And this is a year out. So that's kind of what we're thinking, like what would have led to this complication so far out.
Great. You probably didn't hear me at the beginning, but I said nice presentation and there was some clapping involved. So, and there will be more clapping now, which you won't be able to hear.
Thank you.
Thank you very much. All right. Did I skip one somewhere? Because this is the last one already. Maybe it's because people aren't talking as much because it's all online, right? All right, so our last spectacular problem, colonic endometriosis, a case study of obstructing sigmoid endometrioma, to be presented by Caitlin Stevens from Genesis Regional Medical Center.
All right, can everyone hear me?
As soon as I unmute, yes, we can all hear you. Thank you.
All right, perfect. I'm Caitlin Stevens, a second-year general surgery resident. I'll be discussing a case that I actually saw during my intern year regarding colonic endometriosis. The case studies ultimately revolves around an obstructing sigmoid lesion that was treated and worked up in lines of a sigmoid colon carcinoma. It was worked up by our Carolyn Haas, who's one of our medical directors in the pathology department at that time, and Dr. Tariq Wasfi, one of our trauma surgeons who also operates a robust general surgical practice. I have nothing to declare. A little bit of background. Endometriosis is a fairly common benign condition present in about 1/3 of reproductive age women with chronic pelvic pain, in which endometrial glands and stroma are displaced from the uterine musculature outside of the endometrial cavity. While the ectopic endometrial implanted foci have a recognized propensity for the pelvis, they may occur nearly anywhere in the body, including the intestinal tract. Although it has been well established that endometriosis is a common gynecologic problem in reproductive age women who present with pelvic pain, dyspareunia, or infertility, no one theory has conclusively elucidated the pathogenic mechanism to explain why women ultimately develop endometriosis. And while the histopathologic diagnosis is usually straightforward and based on the recognition of endometriotic glands and aberrant sites, several unusual aspects may raise concern for pseudoneoplasm, including atypical endometriosis, mass-forming lesions, polypoid growth, lymphovascular or paraneurial involvement, necrotic xanthomatous nodules, dysmenorrhea, dyspareunia, abnormal uterine bleeding, pelvic pain, and infertility comprise the most common signs and symptoms. Generally speaking, the type and severity of symptoms are dependent on the extent of disease, the location, the organs involved. However, even limited disease burden has been known to cause significant symptomatology, while the morphologic appearance of an endometriotic implant has shown little correlation to the extent of symptoms. Inconsistent clinical presentation, similar radiographic features, and colonoscopy with other inflammatory or malignant lesions of the bowel make the preoperative diagnosis of bowel endometriosis challenging. Here, we evaluate the case of a gravida 0 para 0 41-year-old perimenopausal female, clinically presented, investigated, and managed in the lines of carcinoma of the sigmoid colon. She subsequently underwent exploratory laparotomy, lysis of adhesions, sigmoidectomy, and proximal colostomy. Pathology demonstrated endometriosis of the sigmoid colon. Thus, bowel endometriosis must be considered a differential diagnosis in reproductive age women with patterned, cyclic, gastrointestinal symptoms and intestinal masses of uncertain etiology or diagnosis. We have a 41-year-old female with Charcot-Marie tooth and syringomyelia who presented with complaints of sharp, stabbing, intermittent bilateral lower quadrant abdominal pain for 2 months. She denied a prior history of similar symptoms, no reported fevers or chills, although she did endorse decreased tolerance to PO intake secondary to nausea with multiple episodes of bilious, non-bloody emesis the day prior to presentation. Her last bowel movement was the morning of presentation, characterized as a small formed bowel movement without melon or hematochezia. She does admit to passing pellet-like stools during her menstrual cycle across the past 1 year. Her most recent normal caliber bowel movement was the week prior. She had a prior failed attempt at outpatient colonoscopy in April of 2019. She presented to us in about September of 2019, secondary to an inability to tolerate the prep, as she could not pass enough stool to fully clean out her colon. Her most recent complete colonoscopy, secondary to pelvic pain, in 2014 was benign. She denied any recent weight loss or night sweats, and she did have a prominent history of malignancy on her mother's side, including colon cancer and multiple second and third degree relatives. She denies any known personal or family history of Crohn's or ulcerative colitis. Her normal cycle length she described as 28 days, with 1 day of heavy flow, 2 days of regular flow, and 2 days of light flow. She utilized oral contraceptive pills, specifically Janala or Luestrin, since age 19. She denied hot flushes, sweating, or chills. And across the past year, she did endorse gaseous cramping in her lower abdomen with the onset of menstruation that actually necessitated 3 days off of work per month. She denies prior episodes of pelvic inflammatory disease and states there have been no prior attempts at fertility. Her physical exam revealed a softly distended abdomen that was non-tender, without rebound rigidity or guarding, and she was non-peritoneal. Her rectal exam revealed no blood or stool on the glove. However, she did have an appreciable, palpable mass anterolaterally in the rectum. Her workup consisted of a CT abdomen pelvis that revealed marked distension of the distal, descending, and proximal sigmoid colon to the level of a questionable intraluminal mass that measured 4.2 by 6 by 4.2 centimeters. She additionally had a CT of the chest to rule out metastatic disease that showed no evidence of metastasis. And this was actually her CT scan that we got on initial evaluation. And you can actually see this intraluminal mass measuring 4.2 by 6 by 4.2 centimeters. She additionally had tumor markers that were obtained that revealed a CEA within normal limits and a CA 125 was markedly elevated. Her vaginosis triple screen was negative, and she had a transvaginal ultrasound that revealed a heterogeneous irregular appearance in the left adnexa with fluid and tenderness on scanning. It was noted at that time in the setting of the elevated CA 125 with the transvaginal ultrasound findings that malignancy could not be excluded. She underwent flexible sigmoidoscopy to approximately 12 to 15 centimeters, secondary to extrinsic colonic obstruction with an inability to pass liquid through the area in the setting of normal appearing colonic mucosa. She was then counseled on surgical intervention for suspected intramural sigmoid colon mass. There was a palpable mass in the sigmoid colon with the left ovary and fallopian tube connected. She subsequently underwent exploratory laparotomy, lysis of adhesions, rigid sigmoidoscopy, and sigmoidectomy with oversew of the rectal stump, drain placement, and descending colostomy. In conjunction with the OB-GYN colleagues, she additionally underwent left salpingo-oophorectomy, right salpingectomy, and as the left fallopian tube and ovary were noted to be adherent to the sigmoid mass, they were removed en bloc. The post-operative histopathological report revealed extensive endometriosis involving the muscularis propria and the serosal surface of the colon and ovary, with fibrinous serosal adhesions of the sigmoid colon, the left fallopian tube, and ovary. Her right fallopian tube was benign with peritubal cysts. The lumen of the colon was strictured and measured 3.8 centimeters in internal circumference. The remaining colon demonstrated an centimeters. The colon wall was thickened, averaging 0.6 centimeters. Sectioning of the area of adhesions revealed fibrosis and scarring, and washings were sent for cytology and resulted as negative. Occasionally, endometriosis forms lesions precipitating mass effector infiltrates in the bowel wall that mimic a neoplasm, primarily colonic adenocarcinoma. Distinguishing features that differentiate endometriosis from malignancy are the predominantly mural location with a characteristic outward to inward growth pattern, and the minimal to absent mucosal involvement and the vital identification of 4 key features. This right here is one of those 4 key features, the endometrial gland itself on the lateral aspect of the larger photo, the stroma, which is this inner layer, contiguous with the glands. The stroma and glands themselves are nearly pathognomonic for endometriosis. And this is the actual bowel wall itself. You can see the smooth muscle fairly easily here. And we also have the old hemorrhage that can be appreciated as hemosiderin deposition, this yellow to brownish appearance that we can see. That's one of the distinguishing features as well, and it's seen more readily on this smaller left-handed photo off to the side. Endometriosis treatment itself is largely dependent on 5 key factors: the severity of symptoms, the extent of disease, the location of disease, the patient's desire for future fertility, and the age of the patient. The treatment consists of a combination of surgical intervention and pharmacologic therapy. Specifically, if there are features of intestinal obstruction, surgery may be required. In summary, endometriosis is characterized by extrauterine endometrial gland and stromal implantation. The most common site of extrapelvic manifestations is intestinal. Colonic endometriosis occurs most commonly in the rectosigmoid area, nearly 72 to 95%, as was evident in the index case. Classically, symptomatology is cyclic or aggravated during menstruation, as evident by our patient. Preoperative evaluation and definitive diagnosis of such colonic manifestations are often inconclusive and challenging in terms of clinical presentation, understanding the correlative symptoms, radiologic recommendations, and surgical or pathologic findings. Endoscopic biopsy has a limited role as the mucosal layer is rarely impacted in endometriosis, and radiographic evaluation may suggest other etiologies or inflammatory or malignant lesions of the bowel. Surgical intervention and histopathologic correlation may be considered. In the index case, the preoperative diagnosis was sigmoid colon cancer. While the clinical presentation can vary from asymptomatic to gastrointestinal bleeding, nausea, emesis, cramping, abdominal pain, constipation, diarrhea, painful defecation, even intussusception, rectovaginal colonic masses, obstructions, or intestinal perforations. Colonic endometriosis is to always be considered as one of the differential diagnoses in reproductive age women with gastrointestinal symptoms or masses of uncertain diagnosis. Management for colonic endometriosis ultimately requires a multiple disciplinary team approach and follow-up. Thank you.
I'm sorry, we didn't get that. Could you repeat that? No, I'm just kidding. There was a lot of clapping here for you, and there is one question in the audience so
Yes.
far.
Well, I don't understand why you get a heart infection. Why not just put it back together if you need to the Gilead close.
So the question from Dr. DeBoard was, you've got a pretty healthy person. Rather than doing Hartman's procedure, why didn't you just go ahead and reanastomose her?
That is a great question. Thank you. So intraoperatively, there was a substantial amount of adhesions, and it was found to be technically difficult to identify the distal portion of the large bowel secondary to the massive amount of adhesions, which would have led to an incredibly Intraoperatively, with both the surgeon and the fellow OB-GYN colleagues that were in on the case, it was deemed risky at that time. And the decision was ultimately made to leave a reanastomosis for a later procedure.
Do you think that'll be easier going forward?
So our patient actually came back about 6 months afterwards for reanastomosis, and it was found, she was found to have a significant amount of endometriosis within the rectosigmoid junction at that area, nearly in the same area, with increased amount of fibroids in the uterus. And an attempt at rigid proctoscopy was only able to be advanced about 13 centimeters, still 3 centimeters away from the rectal oversow. And that procedure was actually aborted, and she was referred to one of our colon and rectal surgeons for reanastomosis, which has since been successful in nature. And she is now on medical therapy with her OB-GYN as well and is doing remarkably well.
Along those lines, did you consider diagnostic laparoscopy before proceeding with your initial operation?
I believe we did consider diagnostic laparoscopy, but due to the extensive amount of adhesions and the actual location of it, we did not actually pursue that even initially. We went right for a laparotomy procedure.
So another question, why did you not restore bowel continuity? I think you answered that one already. Textbooks talk about resection of some of these. Knowing what you know now, do you think this is feasible more or less often?
Resecting or primary anastomosis?
No, just initial resection of this before it gets to this point.
So we actually didn't have a diagnosis of endometriosis prior to the case. She had come in previously and had been worked up by the gastroenterology team and our OB-GYN colleagues. And had we had a diagnosis of endometriosis prior to the surgery, I think it would have been beneficial to have her work closely with the gynecology department to potentially be on hormonal therapy, which could have downsized the size of any rectosigmoid stricture that she may have had and lessened the endometriomal burden and potentially lessen the severity or extent of the operative intervention that we had to pursue in order to relieve her of her obstructive symptoms at that time. But we did not have a pathologic diagnosis until the procedure.
Great, thank you very much. Any other questions? So this concludes our first official virtual spectacular problems. I think it went very, very well. Thank you to all the presenters, and thank you to those in the audience and those online. There's a couple housekeeping things. So for those of you online, the meeting will start at 7:45 tomorrow morning. That is Eastern time. So we are Eastern time here in Michigan. So 7:45. It starts earlier tomorrow because there is no 5K tomorrow morning as there is usually. Which means that for those of you online or even here that are participating in the virtual 5K, you do not have to send your results in until 8 a.m. Tuesday morning. So you have a whole extra day to send your results in. Do not, if my son contacts you and asks you for your time, do not give it to him because he is asking people and he's going to go less than your time. Which is not fair, obviously. But so if you hear from a Christopher Godellis, do not give him your time. There's a question here about, for those of you online, how to submit questions. And I guess the Q&A session is, or the Q&A tab is easier way to submit questions online here. Anything else, housekeeping? There was some confusion about whether or not we were offering CME, and we are offering CME both for the people in person and the people online. Loyola University, I have to put a plug in for my own university. We were able to get a discounted rate from them. And so everyone here that attends session and participates will get CME for this meeting. I probably need to make sure I thank my wife now because I may forget to thank her later since I'm not giving a presidential address. So let me just go on record to say I thank my wife for supporting me. And thank Margie and Jill, especially Jill, who's here from LP, our management company. And we have lots of extra time, so enjoy your night. For those of you at home, enjoy being safe at home, and we will see you all bright and early tomorrow morning. Thank you.